an image that's really kind of haunted me for about the past 6 months, and it comes from a eulogy that was written by Mona Simpson, who was Steve Jobs' sister, writing about Steve Jobs in his hospital bed, designing all these gadgets and covering healthcare. I just kind of get the feeling that those gadgets aren't actually reaching patients. That instead of having Moore's law in the drug industry, as was recently noted in Nature Drug Discovery, we have Eroom's law, which is Moore's law backwards. Instead of having computers everywhere, we're just kind of adopting them into hospitals now. So we have three experts who are going to tell us really how we are going to actually bring some of these technologies to patients and actually integrate them into the healthcare experience. And Carrie McClellan, who's going to talk to us about disrupting healthcare by making it more patient-centered. Kent Lawson from Abbott, who is focused on who is focused on making a drug company have an innovation culture, and Nick LaRussa from Mayo, who has a similar job at the Mayo Clinic, and I'd love it if they could all come up now. Gary? And we're going to start off with Carrie talking about how we actually can disrupt the healthcare system by making it patient-centered.
Thank you very much.
And Carrie, I think this is the slide clicker. Do you want it?
Sure. I guess the first thing is to give you a quick overview of our company. We're a Canadian company, started about 8 years ago, and it came from my personal interest in wellness and also the fact that I was involved for the last decade with our hospital foundation and got tired of buying new MRIs and PET CTs and that sort of thing, and thought that we had to do something different. So we started Apple Peak, and this is really our coming out event after 8 years and about 250,000 development hours into the company. We're now launching and we're going live actually this week and next week. So this was based upon 4 principles. The first is that there were 4 stakeholders in the healthcare system: the individual, the professionals, the organizations, including corporations, and other stakeholders who really needed evidence-based data. And we had to deal with all of those stakeholders. So in terms of the first one, the individual, I'm not going to try to go through the slides. I'm only going to hit 1 or 2 points on each one. But we said fundamentally that this had to be, the model had to be turned on its head. EMRs and EHRs are really system-based approaches that come bottom up from the professionals. And our view was that it had to be about the individual. And the main reason for that is that healthcare is probably the last industry in our economy that has not moved to a self-service model. So if you think about banking, travel, you go on the internet, when's the last time you were in to see a teller? And you couldn't go back. So this has not only allowed innovation in those industries, which hadn't had innovation in a long, long time, but it also ripped costs out of the system, significant costs. And so what we wanted to do was do the same thing. You think about when you move to a self-serve model, basically no 2 people have the same profile in terms of the products they use, the connections they make, etc. And we believe that this has to happen in healthcare and has to be recognized in healthcare. The next thing that principle we had was that from an individual perspective, it was if you're going to move to a self-serve model, then there had to be education. So it's one thing to give a person a health risk assessment, get the results, but then how do you move to the next step of recommending programs, recommending courses, etc. So we took the largest static database of health information from HealthWise, and we developed technology to turn it into courses, e-learning courses. We have about 7,000 of them now. So they can either be recommended by your physician or automatically recommended as a result of the assessment you took. From a professional's perspective, I guess it enables new collaborative care models. So that's sort of the holy grail where you talk about, you know, as we'll say in a heart rehab clinic, having a physician, having a nurse, having a kinesiologist, a nutrition. How do you enable that collaborative model? And that was an important part. And the next was to give certified content. Because one of the big complaints that professionals have is that people walk in their office after going to the internet and they spend a lot of their time debunking what they found. Finally, I use the word corporations here because that's, I think, going to be the easiest channel to get there. And what they're looking for is proven results, measurable results, and comparative results. And they want to be able to step into the water slowly, so a cloud-based model. The next one is probably the most key. Is the evidence-based nature. So our product was built upon going back, trying it, redoing, trying, etc. And we believe that there's multiple sources of data, professional data, personal data, and also, as the last presenter talked about, new devices. This is going to be one of the largest growing areas. But it reminds you of Microsoft, 15 years ago, where if you bought a new peripheral, each one was different. They had different protocols, communication ways, etc. And Microsoft acted as an integrator in that. So one of the things we did was to be able to integrate most devices and also to present a broader view, because most people have different conditions, whether you have diabetes, heart disease, etc. And for the patient and the physician, the professional, to be able to see all those in a single view. And the final one I'll talk about in terms of data is the pharma industry. There's been some fundamental changes where the pharma industry is under pressure to do post-surveillance marketing on their products, and also to look for different ways of repurposing products. We've designed our data models so that we're going to be able to mine them and provide them with that data at a fraction of the cost of doing complete new studies. So one of the studies we did was with Dalhousie University and the heart rehab clinics in Halifax. And it's supposed to be a 3-month rehab program. Well, we followed them for 9 months and let them use the technology for 9 months. And medical adherence, our pharma adherence went to 99%. And the results we got in terms of drops in cholesterol and enduring results were, they were off the chart. So we ended up being asked to present in the European cardiovascular session in Munich. So obviously I'm out of time. I hope you'll take the opportunity to drop by and see our product. And thank you
We
very
have time
much.
for a quick question from me, and I'd like to know a little more about this. What did you give them? What did you tell them that resulted in, I mean, such a dramatic increase in medication adherence? I mean, Express Scripts will tell you that that the cost of non-adherence in conditions like this is actually bigger than or I guess it's about half the size of the drug market, but it's huge. What was the technology telling these people that kept them this engaged? I mean, 99% medical adherence, that's incredible.
Well, what we went and did was there was a partnership between us and Shoppers Drug Mart and the other physicians, and we enabled people to report daily whether they had taken their medications, and if not, why they hadn't, couldn't afford it, ran out, etc. And this was being monitored by a pharmacist. That pharmacist was able to intervene on a real-time basis and deal with the situation. The original data point without a pharmacist was less than 20% adherence. And having a pharmacist involved with no technology took it to about 60, and then using the technology for real-time monitoring took it to 99%, and that held through the entire study.
It's really neat. Okay, now, and I'm going to switch things up on the panelists now. They've obediently seated themselves in the order that we'd put them. But I'd like Ken to go next, and then we'll have Nick back clean up, so that I think it would be better to end with the actual delivery of healthcare.
Thanks, Matt. So is this on? Can everyone hear?
We can hear you.
So thank you. A couple of things. First of all, I think there's no better time to be in healthcare. I think that there's so much changing. It's the perfect storm with cost constraints, both here in the U.S. as well as Europe, Japan, Asia, Latin America. That's driving lots of change, but also patient behavior, consumer behavior. And we've heard, I thought the retail panel was great in that they talked a lot about experience. They talked a lot about prototyping. We heard about prototyping with Thomas Edison today. That's really important. All of these things are happening also in healthcare. And we also heard about mobility and how mobility and mobile devices, smartphones, are really making an impact in the retail space. They are as well in the healthcare space. We just heard Carrie talking about technology and its impact. I'm sure Nick will have some thoughts on that as well. One of the things so I work for Big Pharma, right? A $40 billion pharmaceutical and medical device company, soon to be a $20 billion pharma company. And I have two sides of my job. Number one is to get all of us in the company closer to our patients. And that is a big shift in the way that Big Pharma has been talking about or acting or working for the past probably 30, 40 years. It's always been provider or prescribing doctor-centered, and that is shifting dramatically over to the patient, because it is now the patient that is holding the power, the patient that is holding the information, thanks to the internet, thanks to the mobile devices, thanks to social networks. And so the patients are walking in the doctor's door certainly better informed, but oftentimes the doctors are so stretched, and this is happening globally, the doctors are so stretched for time that it's the patient advocating for their own selves that's driving decisions within the exam room. And I'll give you a couple of one for instance. It's very personal story. So, past couple of years, I've gone to my doctor, my general practice doctor, and my blood pressure's been high. So he says, well, it's probably just a white coat syndrome, right? So I wrote that off. Yep, probably just a white coat syndrome. He's right. I'm a little nervous coming in to see my doc. So yep, that's what it was. So it happened again 2 years ago. So I just said, I'm going to start tracking this myself. And so I pulled out found my app, bought a blood pressure cuff, and I tracked it for 6 months and found out that it wasn't just white coat syndrome. It was, in fact, a little bit high. So the next time I walked into my doctor's office, I took out my iPhone, and I said, hey, doc, check this out. I've been tracking this for 6 months, and look at the results I've received. And he said, oh, I don't have time for that. Just tell me what they are. I said, well, I'm trending high. Well, what are the numbers? And so I gave him the numbers, and he said, okay, we'll put you on a medicine. So not exactly what I wanted to hear, right? And I loved Andrea's introduction to this session, that Thomas Edison said that doctors will be people, in the future, doctors will be people that will get patients interested in health and interested in their own bodies and interested in their own wellness. That is happening, but not through doctors. It's happening through mobile devices. It's happening through apps. It's happening through social media. And so that's the really exciting place, and that's where I'm trying to push big pharma, this industry, healthcare in general, to move into that space. And I think it could not be a more exciting place to be.
And just quickly, Ken, being at a place where you're looking at per product innovation costs in the many billions of dollars, which is a pretty big weight for any innovator to have on top of them. How are you finding the culture? How can somebody who's looking at designing a chemical that's 10 years from the market at best think about where things are going to be in that amount of time with this kind of creative destruction of medicine going on?
Right. So I'll back up and talk not about pharma right away, but when A.G. Lafley became the CEO of Procter & Gamble, actually I believe the stock went down. Wall Street didn't think he was the right guy for the job, and so the stock actually went down. One of the first things he did at Procter & Gamble was he said, we are going to become a consumer experience design company. He said, we are no longer going to be a chemical design company. And I think that same shift is, I'm hoping to create that same shift in our company. And that is, I want to, certainly the molecules that we design are very, very important. And they will continue to be important. I mean, they are truly miracle drugs for some of our patients. But beyond that, we need to start thinking about the entire patient experience, the services that we can bring to bear on their lives, the connections that we can make, the adherence, understanding the adherence burdens and designing experiences that get over those burdens. It's all of the things that are outside of the molecule design that all of us in the business have an opportunity to change and innovate.
All right, Nick. Well, unlike the rest of us, you actually deal with patients. So
maybe I should start with a disclaimer. A, I'm not a primary care physician, and B, I don't take care of hypertension. What I am is a physician scientist, and that's relevant to my comments. I'm actually a super sub-specialist, which means I know more and more about less and less. But as a physician scientist, I bring a perspective to the broader challenges of healthcare. And so I've now accepted the responsibility to develop the Center for Innovation at the Mayo Clinic, which I'll expand slightly on because I think it's relevant to the discussion. But let me begin with what scientists do, and they propose hypotheses. So let me propose several hypotheses, and if you remember nothing from what I'm going to say today, these are probably the things that you should remember. One of them is a pickup on what Ken said, but I'll say it differently. Healthcare is the industry of the next. The focus today is on the future and on the next. Healthcare is the industry of the next. Secondly, the challenge and the opportunity is the translation of discovery to delivery. Discovery to delivery. And thirdly, the tools that are going to be required to translate discovery and delivery are technology, traditional science, and in my opinion, and I think Kent coming from IDEO will agree with this, and many of you will, design and design thinking. So those are the three hypotheses. Well, let me begin by explaining why I think the translation from discovery and delivery is so key. First of all, if you divide medicine into science and service, discovery and delivery, since the Second World War, there has been no industry that has been more innovative than medicine when it comes to the science. In the last 60 years, we have learned more about disease. We've developed drugs and vaccines. In fact, we've cured polio. Cervical cancer will disappear from this country in the next decade. And we have machines that can explore the innermost parts of your body without making an incision. So from the point of view of the discovery and the science, there's been no industry that's been more, in my opinion, innovative than healthcare. The problem is with the delivery. Nothing has changed in the last 100+ years. We're still a fee-for-service, volume-based model that, by and large, is fragmented and requires you, with difficulty, to make appointments, usually in series, if you have chronic, difficult, challenging problems, and face-to-face visits requiring you to go to somebody's office. That's what exists now, and that's where the opportunity to change is. So that's kind of the way we began the Center for Innovation 4 years ago. The focus is on transforming the experience and delivery of health care. And Mayo thought it was important because even though we're enormously successful and highly trusted, the adaptation and the modification that we need at the beginning of the 21st century is monumental. We're also, we focus on the comment that George, not Mitt, Romney made about the auto industry in the 1980s. There's nothing more vulnerable than entrenched success. And in fact, entrenched success in industry is what often serves as an obstacle to innovation. So let me just conclude by saying we've put together a group of individuals. We probably are the first institution that have embedded designers in our practice. Using the traditional scientific method, we have laboratories. We have a laboratory in the outpatient practice where we study the interaction of patients and providers to figure out new ways to deliver care. And we have a laboratory in an assisted living facility because we believe, as was mentioned earlier, that with the aging population, one of our goals should be to figure out how to keep people alive and independent in their homes for as long as possible. So I think I'll just stop there and be happy to expand or answer any questions that you might have.
Well, Nick, why is it so? I mean, it's hard to think of a field where it's more difficult to make design work in some ways, because design solutions are have been relatively hard to prove in healthcare. We have this. We're like the worst Microsoft PC where you're adding on peripherals, as Kerry put it. We're adding one thing, and then we prove this is better in this RCT, and we prove this is better, and we have this device, and there doesn't seem to be any system to me for combining all that stuff in one place.
I don't actually agree with you, Matt. I think
I was hoping that would be true.
I think that healthcare has been behind other industries to recognize the value of design thinking and designers. When I first hired, with the help of IDEO, a few designers to put in our first outpatient lab, when I talked to my physician colleagues about designers, they thought they were people who made chairs, and they are people who do that, but they also have an approach to problem framing and solving. And in our institution, I now have close to 15 designers working embedded in the outpatient and Hale laboratories, and I have a growing number of requests from colleagues within the organization to help me help them recruit designers. Mm-hmm. These are basically people who do research, but in a very different way from the way I do research in my basic lab. Mm-hmm. And I think if you look around the country, increasingly, academic medical centers are recognizing, as other industries have, the value of designers to frame and help solve problems related to the complexity of the delivery of healthcare.
And Matt, if I could add to that, I think that as complexity grows, the need for creativity grows even more. And so there is no more complex industry than healthcare. the delivery systems, the pharmaceuticals, the way we deliver, the patients, the reimbursement systems. And so that complexity is a perfect environment for designers to live and to breathe and to really think differently, because they're not constrained by the analytical or the linear approaches. They're coming at problems or the complexity in really different ways.
Now, Ken, I think a lot of my sources in the pharmaceutical industry would tell me that they are a design-based industry, that they have been a design-based industry. They design drugs. How is the design that you're bringing in different from the design that's already there, and how do you see them meshing?
Because healthcare is becoming less about the thing and more about the behavior or more about the experience. And so as we're moving into this experience world of healthcare, the analytical, yes, we design drugs. Yes, we still do evidence-based design on molecules, but we need to move that to evidence-based design on behavior as well.
And Carrie, how do you see, you talked about the Microsoft PC, which I think is a great image because we all have our past love-hate relationships with Windows and machines. I mean, how do you make that work in healthcare? Obviously,
If you take a look at some of the electronics stores, their big category coming in the next few years is basically these automated products for measuring your blood pressure, measuring your fitness, your weight, wireless scales, diabetes devices, etc. But if you have to look at silos at the information, then that's going to be of limited value. Very valuable for the person with a single modality, or a single issue. But we see the need to bring that all together, like Microsoft did, get rid of the complexity of different protocols, different communication, and have it all come together seamlessly. If you can do it seamlessly, then you're going to turn your home into basically the first stage in healthcare delivery.
how do we make sure this change strengthens the patient-doctor relationship instead of destroying it as fee-for-service tends to?
I'm not sure you'll like my response to that. I think there are certainly generations who believe that the patient-doctor relationship is key. If you look at the younger generation, which is interested in immediate information, they may be much more interested in getting the information than establishing a relationship with a physician.
Well,
If Watson has the potential from IBM to answer questions in nanoseconds, that may become the alternative to the physician-patient. I don't know what the future is going to hold, and we can argue about whether you agree with me or not, but the generations have different perspectives about what they want from healthcare.
But-
I couldn't disagree anymore.
Well, the flip side is that lots of people my age, younger than me, may never have had much of a patient-doctor relationship as a result of the current system.
And that's one of the problems.
That's fee-for-service.
Well, I don't know. So I don't know. I think that patients, younger generation patients, they're trying to have a healthcare relationship, but it may not be a one-on-one relationship with their doctor. I mean, the work that we did at IDEO for years and years saw the sort of the doctor not being the primary place where patients were getting information and experience. It was moving actually to the pharmacist, because the pharmacist was there on a neighborhood. I mean, they had the time. Their incentive structure was that you come back and use their pharmacy and buy your milk and buy your beer and buy cigarettes at the pharmacy, right? So the relationship shifted because of the incentive structure we currently have in the U.S., where doctors are incented to see more patients and to only spend 6 minutes. How can you establish a really personal relationship in 6 minutes a year? Really tough. But how many of us spend more than 6 minutes on Facebook every day? I'm guessing it's probably quite a few in this room.
It doesn't have to be a doctor, it could be a nurse, it could be a pharmacist.
Sure.
It has to have a human
But I'm also
Okay.
saying that human content might come in through channels like Facebook or Twitter, where you have a trusted network of healthcare clinicians, colleagues, friends, that sort of thing, that are providing health information and recommendations.
Now,
The
as
model
we're-
of, in the past of what you're talking about was the TV show Marcus Welby. Right now, the TV shows are House and ER, and they're very, very different portrayals of what physicians and providers are like. I think
And
that
House
may be
basically is Watson with a drug problem.
Yeah.
I'd
My
like
daughter's
to
a
invite people to
psychiatrist,
start
so
coming to the microphones if you have questions. We have one right there. And right before that, I want to ask one question of all three panelists that I want to make sure I get in. What is the biggest impediment to this kind of change in healthcare that has existed in your mind over the past few years? Ken talked about this being the best of times, which a lot of drug company investors would be shocked by. But what has been a problem that is not a problem anymore? What is the reason for optimism? What problem is disappearing? And we'll start with Kerry.
I think, well, there's a problem. There's a problem of that this gentleman highlighted that's disappearing in terms of we wouldn't think about going to our teller and having a personal relationship, whereas our parents did or our grandparents. Now we only see a banker when we need something that's critical. And the other thing is we've reached the tipping point in the cost of our healthcare system. We can't continue on with our current system, and people know it.
Nick?
I think the biggest obstacle in the past has been the lack of appropriate incentives and the fact that medicine is a monopoly. There was no impetus for healthcare to change because the status quo was financially beneficial to every component of the healthcare delivery system. What's changing now is we can't afford it. We have technology that'll allow us to develop digital medicine or whatever we're gonna call it. And I think, regardless of what the Supreme Court decides, the momentum for change has already started. I think the other thing that's pushing us, and I was surprised this didn't come up in the discussion with the retail group, is retail is moving into medicine now. Other industries are moving into medicine because it's a $2 trillion business. So those are the things that I think blocked it from happening, and what's different about why I think it's going to change.
And now that the insurers have gone accountable care, or started to, they're not going to go back. That's your... What do you think, Ken?
Well, I think as far as impediments, I think the people inside the industry, inside healthcare, were probably the biggest impediments of the past 25, 30 years. I think that we were very narrow-minded in our approach to healthcare, partly because of the incentive structures, partly because we didn't need to think differently. I think that the momentum has started, and we have to change. And I think that things like creativity, design thinking are moving into the healthcare space, and we're starting to get doctors and everyone that's sort of playing in this sea change is tending to think much more broadly about the different connections that can be made. Certainly, looking at retail, having clinical services in a retail pharmacy would have never been thought of 20 years ago. And although I don't think the profit model has been proven yet, it will be. And because it just makes sense. And Clayton Christensen's definition of disruptive innovation, less quality at a lower price, that is exactly what's going on in the Walgreens and the CVS's of the world. And that'll continue to happen with mobile devices and things like that.
Pat Lynch with Women's Radio. You were talking about the delivery part, and you were talking about, well, it isn't all done by doctors, some is done by nurses and clinicians and other people. But last night I was woken up at a very early hour in the morning by my daughter who has something serious going on. She went to her primary doctor, who I recommended actually, who's in Marin County. She's in Nevada. So she had blood work done in February, but she can't get the results until she makes another 3-hour trip back to have a 5-minute conversation with that doctor. What innovations do you see for patients so that doctors may have more contact with their patients without the patients suffering just to get to the doctor?
You're looking at me, but maybe he should answer. try to answer
So,
I actually am looking because I think you brought it up, but both of you have addressed this.
Yeah, well, I think there are a number of things that are happening now. You've heard about the fact that patients are more empowered now. Technology has given them more opportunity to manage some of their own problems. Secondly, what's happening nationally is consolidation of physician groups. But the system is still incredibly fragmented. And the integration of the elements of the entire delivery model is one of the holy grails of medicine. If any of you want to, it was too long to show. There's a YouTube video called "If the Airlines Were Run Like Healthcare." Have any of you seen that?
It's awesome.
yeah, it is.
Yeah. Well, it's awesome in the sense that it's funny and it's extremely well done, but it's extremely discouraging and disappointing. But you know, if you're an optimist, and I don't think you can be an innovator without being an optimist, you see the opportunities rather than the obstacles. I'm sorry about your daughter, but we can talk later if you think that she needs potentially a liver specialist, okay? 'Cause that's
If there's couldn't changes in fee for service alone be the innovation there though? I mean, you know, I was on the phone with my doctor's pediatrician, with my kid's pediatrician last night, and I was thinking the whole time, I don't think they're billing for this. You know, I mean, part of this is just that we're telling the doctor we won't pay you for doing this. Maybe that should be the doctor's role, that they're there when you need to call them in the middle of the night.
Well, I would say a number of things. First of all, one of the problems with the healthcare model now is you don't know what it's going to cost you when you try to get healthcare. There's no transparency of financial information. That's changing. Secondly, the fee-for-service model results in exactly what you predict. If you're going to get more money for doing more stuff, you're going to do more stuff. So that pays for volume. It has to shift towards paying for value, and there are efforts to do that now. The system in Massachusetts is now looking very closely at a totally different model that's not fee-for-service.
Mm-hmm.
So this is all going to happen likely in the next decade, in my opinion. And as you heard, for the reasons that the country will go broke otherwise.
Right. Sir, waiting very patiently at the mic. Thank you very much.
My name's Jim Spivey with Johnson & Johnson. I'd like to get the panel's thoughts on a potential conflict between evidence-based medicine, which kind of requires a skeptical scientific mindset, and this self-service model of medicine where lay people are going to be making their own healthcare decisions.
Go ahead, Kerry.
I don't think there's a conflict. There's, when you talk about a self-service model, you know, you're still going to engage the health professionals. You're going to have multiple sources of data, you know, and in terms of evidence-based, right now we don't have any way of getting that data and making public health decisions, making decisions around that affect pharma, that affect delivery. So in the absence of any data, moving this way is going to provide at least some data, and it'll get better as we move forward. So.
Yeah, I would agree, and I think that, you know, if you ever have a chance to see Todd Park, the United States Chief Technology Officer speak, he calls it the data revolution, and this data revolution is going to change a lot of the way, you know, that relationship between evidence-based medicine on a one-to-one basis, and then opening up doors to so many different services or ways in which we can advocate for ourselves by using or by looking at the data sets.
But isn't there real potential the consumer isn't going to be skeptical enough in a in an environment where they are making all these choices. I mean, right now payers are making a lot of these choices, but I think if you look at the debate over genomics, I mean, I kind of think of this as the great collision we're having, where you've got people who are even active in the genetics field who are writing papers saying, oh, all that stuff, it's never going to be any use to you. It's never going to be, you're never going to want to know about all those little bits of DNA. You're just going to get scared. And then you have people in California who are like, sequence me, come on, I'm ready. I want to know everything. And they are making decisions on some of what might not be entirely validated data at this point. I mean, it's incredible the amount of information that's there, but we're not sure about a lot of that stuff. I mean, is the consumer going to be smart enough to do this? Is there some reason for paternalism here?
Well, maybe I just rephrase it. I mean, I think there will still be a role, in spite of what I said in response to you, for educated providers. And I think the impression that all of current medicine is evidence-based is probably a little overstated. With regard to the genomic revolution, it's very early on. Once we get to the point where you can have your entire genome sequenced for under $500 in less than a week, the evidence will accumulate over time as to the potential benefit and relevance of that. But it's very early on. Don't forget, we only described the human genome, a decade ago? So,
right now we're probably close to that price point for the data. We just don't know. It's just going to cost 10 times that much to analyze it. But, okay, who else? Are there anybody else? You, sir?
I thought I'd never get into this, but the delivery of health care in the United States is a mess. You have to look to Canada or Great Britain, away for fee for service. Otherwise, it's going to break us financially.
Well, what should innovators be thinking about in terms of the shifts in the healthcare model? What do you folks think about that? I mean, we're obviously moving away from fee for service, but to what, and to what degree should someone creating a new technology care?
Well, it impacted our decision as to where we introduced our product, because of the fragmentation and the difficulty in the U.S. System. So, being Canadian-based, there was a natural, bias to testing it in Canada. And you're right, Great Britain. Now we're looking at the U.S. and saying, how do we crack that nugget in a system that is so fragmented with so many different stakeholders that don't exist in other markets. And we think we have a way, but it is very challenging.
Nick, how should we think about the move to the ACO model if we're trying to innovate?
Well, I mean, I think if you look at the elements of the countries that you mentioned, especially the UK, that seem to work by whatever definition, it's having a well-established primary care system of networks throughout the country. And I think that's what we continue to think is important. Now, what that will look like, how we're going to deal with the expected 80,000 physician shortage by 2020, it's going to, as you suggest, involve people probably other than physicians. It's going to involve teams of people. It's going to involve transforming the way communities deal with health. Technology is a necessary but not sufficient component of this, because the infrastructure involving personnel is going to be key.
And continuing to push or design systems for individual users, individual consumers of health. And if we're talking about accountable care, that's where the accountability lands, right? So if you want to smoke, go ahead and smoke, but I don't want to pay for it, right? And data and the system change, if we all put the patient or the user, the healthcare user in the center of everything that we're doing, I think some of these questions will be answered quite readily.
I have a question. I have a microphone.
So you get to ask.
Curious with the fee-for-service model and how these local clinics at Walgreens and CVS and having these longer extended hours have impacted the industry as far as people getting a face-to-face contact, but they just have a cold, so the need to go into a physician's office it's a nurse practitioner or whatever, and they're prescribing something, and how that's sort of impacted the model right now.
My own opinion is that the development of these minute or express clinics has been a major innovation. I think what they do is they allow people to have access to care in a more convenient, accessible fashion. Secondly, they reduce the number of individuals going to emergency rooms for problems that don't require what exists in that reduces cost. So I think those now, as you suggested, the business model for that may not currently be optimal, but it has I think it has brought an additional option for people. Try to get in touch with a pediatrician at 2 o'clock in the morning when your kid's got 104 fever. You know, it's probably a lot easier to go to an express care clinic and have a nurse provider take care of the problem.
I think for my generation and the one below me, there's less of a need for the connection with one person all the time, rather just a human being on occasion when you need something. So.
Yeah, the thing I don't think that these clinics have the nut that these clinics have cracked yet, but I think they will, is chronic care. So it's the perfect opportunity for chronic care management, where you can see someone a lot more often. And if they're keeping the data and keeping the, just understanding your lifestyle, but on a more regular basis, on a more neighborhood basis, I think that that will be where these clinics migrate to.
All right, we just got a time's up sign. But could we take the one last question from this fellow here, just quickly? Yeah?
Quick question.
Sure.
The idea of Mayo Clinic having a center for innovation, when we just think of that, which is an innovation in itself, and the ability to optimize the providing care and having ownership for a patient's own health. So along those lines, how does Mayo think about optimizing the notion of having a center of innovation, but kind of synthesizing patients' needs, design innovation, delivery of care? Because just by virtue of the fact that Mayo, that provides care at such a high level, how do we leverage what comes out of that with everybody across the board to get that ownership? Kind of what Applepeak is doing with creating a dashboard for people, but being able to really listen to the patients and what the needs are, and getting ownership of people's health, because we do know that once people get accountable to their health and we can get preventive and they're looking at their numbers, the idea, and Ken Lawson and I were talking about, as an oral health professional, I live in a kind of a, for my patients, I hear feedback, and it gives a competitive advantage of listening to the patient and understanding the compromises. So how does Mayo think about the future and optimizing that whole center of innovation?
Yeah, there's a number of questions in your very thoughtful comments. I would say, first of all, Mayo has a legacy of innovation, especially around delivery, but it also includes discovery. And the Center for Innovation is not the only point of innovation within the organization. I think what it's done is it's got the organization to articulate more publicly the importance of innovation, and it's introduced the concept of design thinking and innovation as distinct disciplines with a body of knowledge that can be learned and taught. The second thing is, you addressed the diffusion of the Mayo model is a challenge. I mean, we've been doing this. Next year we'll celebrate 113th anniversary. Now, other groups are moving very quickly to adapt. But one of the things that makes us very different, which I don't know if it's diffusible, and I think it's critical, is two things. One, we're all salaried. All the doctors at Mayo are salaried. That means we have no incentive to do any more or to do any less. When I do endoscopy, it doesn't matter to my salary whether I do 8 or 12 or 14 in the morning. The other thing is that many academic medical centers, not all but most, are university-based. Universities exist to do research and education. Mayo exists to take care of patients, and it does a lot of research and education because it can't take care of patients. It's a fundamentally different raison d'etre. So the diffusion is influenced, and then we're in the tucked away in the southeast corner of Minnesota. That's a lot different than New York City. And I have a lot of friends in big cities, and the challenges are, you know, my close friend is the dean of downstate. Well, they've got 47 languages they're dealing with there that they have to deal with, and illegal aliens that don't have any. I mean, the problems is, it's so complex. So the diffusion is a real challenge, and a lot of that's going to be driven by reimbursement models, I think. I don't know if that's a satisfying answer,
But we're out of time. Thanks. Would that the rest of medicine could be more like Mayo. Thanks very much, everyone. This is fantastic. It was a lot of fun.